Hi everyone, this is Majdi Hamashi, Critical Care Medicine, President of PAMA. I am joined today by Rami Ahmed. Rami is a clinical instructor of medicine at Yale New Haven Hospital, Yale School of Medicine. And also Rami is the chair of PAMA Educational Committee. So we have done a webinar about COVID-19 a few weeks ago, and this is our second webinar. And we hope we're going to make another third webinar, should be coming next week, hopefully. And we're trying to stay in touch with you and try to stay up to date with the evidence as it's evolving. And the whole webinar this time will be about inpatient management of COVID-19. We're trying to give you practical points. I work in the ICU, so I'll be presenting the ICU care or ICU management of COVID-19. And Rami will be talking about floor management of COVID-19 patients. Rami is a faculty at Yale School of Medicine, and he is a hospitalist, and he is on the front line taking care of COVID-19 patients. And same applies to me. I work in the ICU. Quickly, I want to also brief everyone about PAMA efforts in terms of COVID-19. If you don't know, PAMA it's a charity based in the US, and its goal is to promote healthcare in Palestine. So we know that Palestine has been affected by COVID-19 like all other countries all over the world. And we are trying to stay in touch with practitioners who are taking care of COVID-19 patients in Palestine. So we established a network of providers. We share knowledge between US professionals and Palestinian professionals. And also we are trying to, through these webinars, share knowledge. Also, PAMA is delivering personal protective equipment to Palestinian workers in Gaza and in West Bank. We have already started a fundraiser on Facebook and social media. Some of you might have seen it, and we've already delivered shipments of equipment to Gaza a week ago, and same to West Bank. And next week, hopefully, we will deliver another shipment of supplies and equipment to Jerusalem hospitals. So we are trying not only share knowledge, but also provide supplies that help them take care of COVID-19 patients in a safe way. So without any further ado, I'm gonna give the platform to Rami to start his part of the presentation, and I will do the second part. We're gonna try to make it a little interactive. The reason this webinar is not live is the time that we are doing it at 9 p.m. Central Time now. So that's kind of not a perfect time for everyone, especially for our people in Palestine. They are now sleeping, but we're gonna record it and we're gonna publish it and share it with everyone who might find it useful anywhere in the world. So with that, Rami, you can go ahead, and I'm gonna be moving slides for you, Rami. So if I don't get it to next slide, just please say next, and we'll make it happen.
Sure. Thank you, Majdi, for the introduction, and thanks for PAMA for their continuous effort and supporting people in Palestine, actually, and everywhere. It's an honor to be part of this organization. It has been really a challenging month or so dealing with COVID and COVID patients. As much as now we're kind of learning more and more about this disease and managing the patient has been really challenging, especially with continuously evolving evidence. And this is one of the reasons why we decided to make this lecture, is to kind of highlight all what we have as an evidence with in a scientific way and move forward. So as an outlines for this lecture, as you highlighted Majdi earlier, that is going to be two-part mainly. The first part is the inpatient management. It's mainly about inpatient management, and the first part is about general medical floor management, and the second part that you will be talking about is the ICU management. And for my part, I will be talking mainly about 4 points. The first one is patient triaging, and Second was monitoring patients while they're on the floor, and what are the available therapies right now that we are trying and experimenting. And the last one will be discharging patients after they being admitted. Next. So as like a very brief introduction, so as we all know, like now, the COVID-19 pandemic is like rapidly increasing in number and mortality all over the world. I think the U.S. is like heading to reach 1 million cases very soon. The number of mortality actually is very, very high. Also, we've been hearing like, rapidly increasing number in the Middle East as well. At the same time, there's like expanding and exploding actually numbers of studies and articles that we see every day in big journals and very like, that about the COVID management. And with all these, number of articles, like we kind of like, sometimes we feel lost of like what to do with all this evidence. So it has like a critical appraisal of these existing evidence has to be made to support the currently proposed management strategies. So this is like what we're going to be mainly the focus of this presentation. Next. So as we're learning about the COVID-19 infection, and probably this figure like chart is like being circulating around, that we can like now understand that there are probably 2 or 3 phases of COVID-19 infection, and the first one is the virus like stage, the early stage, which is the viral response phase, which is like start like at the beginning of the infection, and can be manifested on the patient with very mild symptoms, including low-grade fever, headache, and probably sore throat. Probably you see very like mild changes in the labs, including lymphopenia and elevated D-dimer. As the infection progresses, it goes to the stage 2, like when the patient starting having shortness of breath and dyspnea, and this is like where they started developing, some X-ray finding, like some finding on the imaging, mainly X-ray and the CAT scan, and probably they enter the hypoxia phase of the disease, and then the last stage, or the late stage, would majorly, affected by the host inflammatory response of the body, with all these cytokines being released. It can be manifested as ARDS, septic shock, and multi-organ failure. And through each phase, there's like proposed kind of treatment for that. Probably the early phase will be just supportive treatment, and then there will be all the other experiment therapies that we're going to talk about in short. Next. So the first one is patient triaging, and based on a very large cohort study done in China, they found that there's like almost 80%, more than 80% of the patients will have very mild to moderate symptoms, and these include, like as I said earlier, low-grade fever, headache, sore throat, and then in 14% of the cases they will have severe manifestation, including shortness of breath, hypoxia, and when we do imaging for them, there will be more than 50% lung involvement. And in the severest form, in 5% of the cases, they will go into respiratory failure, shock, and multi-organ system dysfunction. And the reason why we have to know this is just kind of like to know exactly where to triage the patients the minute they arrive to the ED, or probably if we see them as an outpatient, which unlikely. And also the other very important point is early identification of those with severe illness allow for optimized supportive care, treatment, and safe rapid referral admission designed to a hospital ward or intensive care unit. And probably I think this is like one of the points that Majdi is going to talk later, is that the earlier we refer the patient to the ICU, the better the outcome will be.
Yeah, if I may, Ahmed, add one quick thing here. So if we notice that 81% of patients with mild disease, they just recover, they are fine.
Yeah.
So it's interesting to observe that. So we have seen studies, mainly the one that came from France about the hydroxychloroquine and azithromycin. We'll talk about that. But what I'm trying to say here, imagine taking patients who are not sick, not on oxygen, and that was the French study. They are not sick, not on oxygen, they are barely symptomatic. And you put those patients on hydroxychloroquine or whatever medicine you choose, and you don't compare them with another control arm, and you just observe that cohort of patients, that you give them the intervention you have, and you follow them over time, and you say 80% of them improve. Well, we know that they're going to improve. 80% of them going to improve. So that's why we need to be careful reading the evidence as it comes. That we know 80% of patients will be fine. So unless we have a randomized controlled trial, we really cannot make any conclusions from those studies.
Exactly. Yeah. Besides knowing that, like, the majority of the patients are like really people have very mild to moderate symptoms, and they're gonna just improve by, without any treatment and only with supportive measures. It's very important also to know what are the risk factors to evolve into severe illness. Studies has shown that the age is like one of the most important factors, and in a minute I'm going to show a figure knowing exactly that mortality actually exponentially goes with as the age goes up, that the mortality rate goes up as well. Medical comorbidities as well is like a big risk factors, mainly cardiovascular disease and diabetes. For some reason, actually, they found that hypertension is like one of the most common associated comorbidities with severe illness. And I think still the evidence is not clear why. Chronic lung disease, mainly COPD and asthma, and of course, cancer patient because they are immunocompromised. In terms of symptoms, the cohort studies found that people who present with high-grade fever and dyspnea in presentation, they do worse compared to other people. And if we think about it, like we kind of like, if we still remember that figure earlier, probably these people, like when they present with these high-grade fever and dyspnea, probably they're in the second phase of the disease. So they already passed the first, the phase 1, and now they looks like they're going into phase 2 and phase 3. Next. And also when it comes to labs and blood workup that can, give us a hint who may, do better or do worse compared to other. There are like certain labs or like NDCs that were found to be associated with greater disease severity. Lymphopenia is the most common one, followed by neutrophilia. If the patient has abnormal liver function tests, mainly elevated ALT and AST, also markers of hemolysis like with ALDH, and the inflammatory markers of CRP and serum ferritin, all these has been shown that associated with increased disease severity. There are also other markers that is like when elevated, gives you like a bad prognostic indication, mainly elevated D-dimer, troponin, and the lymphopenia also. The elevated D-dimer is like it has been associated with or linked to a microangiopathic state of patients with COVID-19, and the troponin, as like probably a lot of people know right now, that almost up to 30% of the cases associated with cardiomyopathy and some sort of cardiac damage. Next.
Yeah, thank you, Rami. And if I may also quickly mention one thing here. Like for COVID-19 patients, because we don't know much about them, and the whole disease is about 3 to 4 months old, and we're trying to study it. And so what we are doing, basically, we are putting it under the microscope, the COVID-19, and we are dissecting every piece of info. And we now looking at D-dimer, for example, it is elevated in COVID-19 patients. So should we start anticoagulation and all that?
Yeah.
So, but interestingly, like if you look at sepsis patients, they have elevated D-dimer. And we don't ask the question, should we anticoagulate sepsis patients if there is no other indication for anticoagulation? So
Yeah.
I mean, it is interesting, but I know post-mortem studies that looking at microthrombosis in the pulmonary vasculature, and evidence is coming and evolving, and the IDSA guidelines, we're going to touch on it. They have already looked at those studies and they made recommendations. But what I'm trying to say, much of these markers are elevated in any sick patient that comes to the ICU. When I see them in critical care, most of these markers are elevated. And for troponin, we call indirect injury, type 2 MI. Elevated D-dimer, we say it is a very sensitive marker. It is not specific at all, like 50% specificity, but it's greatly sensitive, 99% sensitive, which means if it is negative, is helpful. So I know if a patient has a normal D-dimer, I'm not worried about DVT or PE in that patient. Yeah. But I just wanted to say that these are non-specific markers.
Yeah, well, yeah, exactly. As you said, like because we're looking at on everything, like with the patient, their labs, their X-rays, their everything, and we're trying to link anything that can help us, triaging or categorizing patient into different, severity categories. I won't be surprised actually if later like that we change our thinking of other diseases as well, or like probably see, our care for other diseases, and like why we're like dealing with COVID in a different way than dealing with sepsis, for example. So it will be interesting to see exactly if this is just like very non-specific things that we're just like overreacting to, or this is probably something that we have to, also translate into other diseases and illnesses.
Cannot agree.
This is the figure I was talking about. This is from the weekly report of mortality and morbidity by the CDC. Although the number of admissions or hospitalization is like very high in the people in the 50s and 60s, but the mortality rate actually is higher, like as we go up in the age, and higher like for people like above 85. And this is like one of the factors, or like kind of like now, or like things that making pressure on physicians on the front line, or probably either in the floor or in the ICU. Like if people, if a patient who comes, 85 or 90 with COVID-19 and he's having severe illness, a lot now, probably it's an ethical discussion, like whether or not we have to, pursue treatment and be very aggressive with your treatment. Like mainly, I'm talking about, putting them on the ventilator, sending them to the ICU, versus just, try to, do just supportive measures and go on, because we know that the mortality rate is going to be very high. Next.
Sure. And I think what Rami, what you're trying to highlight here is the rationing, of resources and ventilators when it comes to who is gonna make it and who is not gonna make it, and that's very interesting discussion. And I know that kind of discussion nobody's looking to, and I hope we're not gonna end up there. But basically, what it is, if a hospital got overwhelmed with a surge of cases of COVID-19, and I have only 50 ventilators in my ICU, but I have 70 or 80 patients who need the ventilator. In all days, we take patients off the ventilator if we think they are not going to make it. It is futile, it's not helpful, or it's not lining up with patient preferences. But what we talk about here is in situations where there's a surge, and what hospitals are trying to be prepared for is taking a patient off the ventilator who might make it, but we know there is another patient who has a higher chance of making it, and we need to give that patient the ventilator. So which is a very difficult ethical dilemma, and we hope hospitals will not end up dealing with that. But such a thing is going to be not, these decisions are not going to be made by the provider who's providing care for the patient. These gonna, each hospital is gonna specify a triage team who will look objectively at the patient factors and go according to criteria like SOFA score and age and comorbidities and all that, and saying this patient has a higher chance than that patient, so we should give it to that patient. But not the treating patient, not the treating provider should be making those decisions, and the team who's making them should be blinded from the patient details.
Yeah, it has been actually challenging. We still like we're not inserted like we're gonna like very desperate for ventilators, but there's like some you know, a lot of talk about, you know, these patients kind of like discuss their COVID status at the beginning when the minute they get like being admitted and you know, giving them all the fact. Still like we're not withdrawing any care, or like we're not like if they like if any aggressive measures has to be taken, we do that. But it's like it's been really challenging to kind of like know this fact and know at some point that if there's like really a bad surge, that based on the age and other comorbidities, that this decision has to be taken. Next, this busy table, just to summarize, this is from a Chinese study looking at the predictors for mortality from COVID in 150 patients at the center of the disease outbreak in Wuhan, China. And as you can see at the bottom of the table, that is like similar to what we talked just earlier, that C-reactive protein, troponin, and interleukin-6 ferritin, all these are like associated with higher mortality. If you compare between the people who died versus who are being discharged. So next. These are like the numbers or like days just to kind of like see exactly the timeline that can also help in triaging patient. The longer that the presentation, the patient is being presented after like starting the symptoms, that the more you think probably that he may need more care. For example, the median time to dyspnea range from 5 to 8 days, and the median time to develop acute respiratory distress syndrome or ARDS is 8 to 12 days, and the median time for ICU admission was like range from 10 to 12 days. So if you have a patient who who presents with started having symptoms like about a week ago, and now he's presenting with dyspnea and hypoxia, these are like the high risk patient. Probably if they have like other comorbidities and they're like very old, these are like the high risk patient that you want to admit them, you want to put them on close monitoring, and they're probably keep a very low threshold to send them to ICU if they decompensate.
Yep.
Next.
And that's exactly why when hospitals are making predictions, we always say what we have today in the community, we're going to be dealing with it next week or in the coming 2 weeks. So
Exactly.
like for example, where I live in Kansas, the predictions are that we're going to have a surge by the last week of April. I hope that will not happen. And I have it's a feeling that it's not going to happen. I hope it will not. But these are important, like that the course of the disease is it's good to know and very important to know to make your predictions.
All right, so talking about the general medical floor management, concepts. First of all, as a general care, like every patient is going to get supportive care regardless of their degree of the illness severity. First of all, every patient has to be isolated, and what type of isolation should be airborne and contact isolation. There's a lot of talk about negative pressure rooms. It's preferable that the patient is being placed in a negative pressure room, but unfortunately, like if there's a high number of patients, that may not be available. So now, for example, we're putting the patient in just a regular room, actually. So at the same time, when it comes to isolate the patient, we have to make sure that all the medical staff are protected with all the protective equipments, including covering their face, the whole upper body, preferably gloves, gowns, at least like probably a lot of people saying like 2 layers at least of protection to prevent any transmission to the healthcare workers. The second point is hydration. Although there's like no specific guidelines about hydration, but there's a lot of talk about being very conservative when it comes to IV hydration, just to prevent the patient from going to pulmonary edema. And then, like as we know that in the management of ARDS, we try to be more on the negative side rather than like positive side of volume. And also for inhalers, and we've been seeing a lot of patients with COPD, and this has been a challenging thing to deal with. So as a general concept, that for now we're not doing any nebulizer treatment in hospital because of risk of oralization of the virus and transmission of the virus all over the place. So a lot of hospitals, they have a policy not to do any nebulizer treatment for all the patients. And instead, if we're using metered dose inhalers, either with spacer or not, in a very exceptional cases, we can do nebulizer, like if the patient is in negative pressure room and all the patient, like healthcare worker, are protected. But so far, it has been really challenging to deal with this. That not giving nebulizer for COPD patients or other patients like asthmatic. Also, patient has to be monitored for either continuously or very in a closed intervals for cardiac monitoring, mainly as we're going to talk later a little bit about hydroxychloroquine. If we're going to start the patient on hydroxychloroquine, there's a risk of prolongation of the QTC. So a lot of patient now is being on a continuous telemetry. The recommendation is to do an EKG for every patient at the time of the admission. And the interval of the vital signs should be at least every 4 hours. And a lot of hospitals right now, they're doing continuous pulse ox for their patients. For labs, as we mentioned earlier, inflammatory markers, CRP, ferritin, kind of indicate the disease severity and progression. And at some point, actually, we base our treatment based on the CRP. It gives us a hint if we have to start any or escalate the treatment algorithm. Cardiac function, troponin, and BNP, kind of to make sure that the patient is not going into cardiac toxicity or cardiomyopathy. Coagulopathy, labs, D-dimer, INR, fibrinogen. Also, I'm in a few slides, I'm going to talk about anticoagulation, whether or not we have to anticoagulate, and liver function test, because as we said earlier, it's like an indication for worse outcome. Now for DVT prophylaxis, as a general rule, and I think probably now everyone agrees on that all the COVID patient has to be, unless there's really strong contraindication, all COVID patient has to be prophylactically given DVT prophylaxis, either with heparin, Lovenox, or low molecular weight heparin, or probably now some people are using the NOAC or the DOAC, the direct oral anticoagulants. As we said, because the D-dimer is associated with increased mortality, now the question is rising, as Mehdi said earlier, do we have to empirically start anticoagulation on everyone? Next slide. So there's no clear-cut evidence about it. And I think that the best answer will come from a controlled randomized trial. There's a study that was done that showed that yes, people who like being anticoagulated did better than the people who were not. So and now a lot of recommendations about even patients like with mildly elevated D-dimer to be anticoagulated with not a full dose of low molecular weight heparin, like now 1 milligram per kg, and instead we use 0.5 milligram per kg if we're using low molecular weight heparin or 7,500 units of subcutaneous heparin every 8 hours. If we can go to the next slide, I will have a table. So this is the table actually we've been using in our hospital. This is basically, it has 3 factors in it: the D-dimer, the BMI, and the creatinine clearance. And for people like very, minimally elevated D-dimer, we use just a regular prophylactic dose of either low molecular weight heparin or the subcutaneous heparin. And based on their BMI and creatinine clearance, we decide the dose and the interval. Now the gray area comes like if they have like above 5 milligram per liter for D-dimer elevation. So now we use the 0.5 milligram per kg for low molecular weight heparin, and the 7,500 for the heparin. And if we think that they're going to be discharged, like now we're kind of like using or utilizing apixaban for that. And if they have a confirmed either a DVT or PE, we just use the regular dosing with like 1 milligram per kg or the heparin infusion.
So,
how about do you have any policy in your hospital?
Thank you. So what I wanted to say, that's what Dr. Rami used at his hospital, but we don't use that at my hospital. And in the same city, you will find another hospital who give heparin empirically to all COVID patients, unless contraindicated. So, but in my hospital, what we do, as you said, we do DVT prophylaxis on all patients, unless there is really compelling reason not to do that. And we do 0.5 milligram per kg low molecular weight heparin, enoxaparin, and we do it once daily. We don't do it twice a day, and assuming normal renal function. If the GFR was abnormal, then we go with the heparin, but we go with the 7,500 3 times a day, a sub-Q heparin, regardless of the BMI. So we just give it high dose to all patients. So that's what we do, but we don't do empiric heparin on all patients. Having that said, if I have a patient on CRRT, for example, and that filter keeps clotting, I just put those patients on heparin infusion because they have COVID and I'm not sure. So as you said, yes, we need randomized controlled trials to answer that question for us. In the time being, we need to do what we think we should do for our patients, and that's why whenever we have no evidence, we get more opinionated. So, and there is nothing wrong with that as long as we're keeping our patients safe.
Yeah, let me ask you a question. So I know, as you said, like we see D-dimer elevated in many like systemic illnesses like sepsis or like septic shock. But have you, for me personally, actually, I noticed that people with COVID, actually, they're like really hypercoagulable. And we've been seeing actually a lot of patients with COVID, especially those in the ICU, having really large, actually, burden of clot in their lungs. Have you had similar experience?
Well, it's an observation. So we have done CT angiograms and ultrasounds on several of them, and actually most of them, they don't have clots. So the ones I took care of. So having that said, I've seen studies where they've seen bigger number of patients. No, they've seen clots on those patients. So as I don't know. So, and again, ICU patients, they are at high risk of DVTs and clotting, regardless what the diagnosis is. And how often we find patients, incidental finding, who have PE, who came in for pneumonia. So am I going to say that pneumonia patients are hypercoagulable? I need to start all of them on heparin? I don't know. I think the way to answer this question is to screen all comers or do a randomized controlled trial and treat half with heparin and the other half make them control and see what happens. And I understand what people who are using heparin, they are coming from that there's a microthrombi, a kind of a clotting disorder you will not see on CT angiogram or even ultrasound for lower extremity. It's a microthrombosis in the microvasculature of the lung. And that is what's causing hypoxia. That's the theory. But again, it's a theory. I started heparin in patients, and I did not notice that their oxygenation improved necessarily over days. Or again, I know I use it to prevent further thrombosis. It is hard. It is hard to tell. I don't know. But
yeah, it is. Yeah, it is just like really challenging.
I have a low threshold to start heparin infusion. How about that? As long as I have contraindication for it, I'll use it. If a nephrology calls me, hey, can we? I say, oh, sure, yeah, I don't see contraindication, let's do it. But I don't do it on all patients empirically. No.
Okay. All right. So back to the management. So as we said, for the mild illness, in 80% of the cases, most of the time, when they when they come to the AD, they just even like when they do outpatient testing, they can go home, they self-isolate, get supportive measures, therapy with antibiotics, and then if their disease like progresses to like the moderate illness, when they have dyspnea, hypoxia, and like we see infiltrate in the X-ray, and they have comorbidities, as we're going to talk in the next slide. These this patient population will need to be admitted, monitored closely, and depending on the the policy of the hospital or the agreement of the multidisciplinary team in the hospital, whether or not they have to be on the experimental therapy, and plus they have to get the supportive measures, all the supportive measures just we talked about the previous slide. And for the severe disease, the second part of the lecture will be about the ICU care. Next. So here, like kind of more detail about the symptoms. The mild cases, just very mild symptoms. Again, we just observe supportive measures. If they feel worse, we advise them to come to the hospital to seek more medical treatment. If they have like any of the mild symptoms plus dyspnea, infiltrating the X-ray, hypertension, then we can, in this case, we can, and if they are like older, like more than 60 years, other comorbidities, we consider them for the experimental therapy. So, next.
Yes, and we do the same. Mild cases we don't treat. We don't give COVID-specific therapies. But if mild with risk factors, we treat. And if they have moderate or severe, we treat. So mild with risk factors or moderate or severe, we treat them. Similar, basically, to what we do.
So what are the what are the available therapies or like now that we can provide or not? Depends, like how we strongly, feel about the current evidence. The most like commonly used one right now is hydroxychloroquine, either with or without azithromycin. Steroid, anticoagulation we talked about. We have the antivirals, multiple antiviral drugs, Tocilizumab, and convalescent plasma. So we're gonna go over them very briefly. We're gonna put the evidence. But we're not gonna like talk about the evidence or like the studies in a detailed way, but kind of like as part of any scientific discussion, we have to put the evidence for the audience and do the critical appraisal of it and see exactly what are the other scientific and medical society actually recommended based on a panel of experts who are like very knowledgeable about all this diseases and methodologies of research. So the first one, the hydroxychloroquine and azithromycin, and the part of why this medication is like very common right now is because of a lot of attention we're getting from the public, and a lot of the non-scientific actually talk that a lot of people we've been hearing around. So as a bottom line, the latest IDSA guideline or the Infectious Disease Society of America just like published their guideline almost a week ago, not even less. And they don't recommend hydroxychloroquine either alone or azithromycin to be used for any patient with COVID unless it's in a clinical trial. There was a lot of debate like after the guidelines were released. People against the hydroxychloroquine. I'm just going to talk about the two main studies that they based their like the support of hydroxychloroquine to that it can be beneficial. Majdi, if you can press next.
And if I may mention here, if you notice the second recommendation about hydroxychloroquine azithromycin, the IDSA guidelines put the word only, and they clarified that on April 15 what they mean by that. So they say if you're going to use hydroxychloroquine, you should use it in a context of clinical trial, but you might choose not to. But if you want to do both of them, they really feel strong that you should enroll those patients in a clinical trial, basically because the risk of complication is higher, mainly cardiac and QTC and arrhythmia and all that. But just like that only word was mentioned, I think 3 times in the recommendation. So we'll try to pay attention to that.
Oh, good point. So how did the hydroxychloroquine came to attention to be used for COVID-19? So it has been used there's an evidence of in vitro effect or like non-clinical studies on SARS or COVID-1. It failed to show an effect on influenza, but it showed in vitro and in vivo studies showed that some promising effect against COVID-19. And this is where now there's kind of people there's an effect on in vitro studies, we have to use it on clinical studies, which is not the natural way of any disease to be tested or approved for human use. If we have to kind of take it phase 1, phase 2, phase 3 critical trials. The evidence comes from human studies actually is a very small number of patients in controlled and uncontrolled clinical studies. And a lot of, you can easily actually make an argument about these studies, about their evidence. And again, one of the people that would say, okay, but hydroxychloroquine is a safe medication. Yes, generally speaking, probably it's overall safe, but it has its own toxicity as well, mainly ventricular arrhythmias, QT prolongation. And there's a lot of reports about people, dying from ventricular arrhythmias first aid. And it also has a gastroenterology toxicity, mainly diarrhea. So this has not giving that evidence. It's really hard to kind of and because of this serious illness, a lot of people say, okay, we have to use something. We can't just watch people getting worse.
It's completely safe medicine. Like in my hospital, we have a patient who had torsade from hydroxychloroquine, and that patient was not an azithro. It was just hydroxychloroquine, had torsade. The patient made it, but it could have died. So it's not a totally benign medicine. And if you use it, you need to do everything you can to mitigate the risks that are entailed in using it. So it's a package. And as you mentioned before, the QTC, and in my hospital, we have a very detailed protocol how to follow the QTC, as you said, establish a baseline EKG and correlate with the QTC and the telemonitor. Once they correlate with each other, you follow daily QTC, and our QTCs are being read, not by the nurses, not by the providers, by the cardiology team. Every morning they read it because they say it can be tricky. And our criteria, we don't start if QTC is above 500. And if once we start, we have to stop the medicine if QTC goes above 520 or it increased by 60 milliseconds. So, and every morning we read, and our cardiology team will communicate with pharmacy, who will communicate with the provider to hold the next dose if that happens. So what I'm trying to say, it's not completely benign medicine. If you want to use it, fine, but it is the the team's responsibility to protect the patient from the side effect and do their due diligence to mitigate the risk, which is basically arrhythmia and other side effects.
Yeah, so I think if the hospital has the ability to monitor the patient and dealing with the side effects of the medications, and they strongly feel that it may help. They can make the case, but they're just kind of just using it haphazardly just because there's some data about it. I don't think it's safe. There are now many trials going on for the hydroxychloroquine. Hopefully something is going to come up soon. Actually, there's a lot of the newly reported that were studies. Actually, there's actually negative impact of hydroxychloroquine on patients. So I think we'll wait and see.
And as you said, so that makes the argument of using it more difficult on ED physicians. Some ED physicians felt okay initially to discharge patients from the ED because they have mild symptoms, they don't need to be hospitalized, but they discharge them on hydroxychloroquine. And some hospitals, they're having heated debate within the hospital to give hydroxychloroquine across the board to everyone. Well, people are not on the same page on this. So what we're trying to say here, yes, you can use it. Most people are using it, but it's not completely benign. Would I give it to a patient as a prescription and go home with it? I'm not sure about that. But in the hospital, yes, I might use it if I want to follow QTC and prevent complications as much as I can.
Yeah, agree. All right. Next, so these are the two studies. I'm not going to go over the detail and the doses, but I have just 2 points. The first one is that the size of the study is very small in both the first one in China, the second one in France. And the second thing, they looked at the viral clearance, which is not by any way as a surrogate of any clinical improvement. So if the medication is clearing the viral load more rapidly than the other one, or no treatment, that doesn't mean that the patient are improving. So that's why a lot of people are making our argument about these two evident studies. So hopefully we're going to have more controlled, well-designed trials in the near future. Next.
That's what we mentioned in the first few minutes in our presentation. We need to be careful with those studies that are coming through, and definitely an observation study like that one by Gottret, I cannot draw conclusions from it. It's just an observation, and most of his were not on oxygen. They were mild disease. They're going to improve anyway. And the randomized controlled trial, it has serious issues with methodology too. They have serious bias issues. So what I'm trying to say, even if we have an RCT, we are physicians. We are not the best people to appraise trials. That's a science in itself, and that's why guidelines are backed up by those methodologists to help them grade and use that grade criteria to appraise any trial, and they come up with recommendations that can be strong or weak, and they come up with level of certainty that can be high, moderate, low, or very low. And interestingly, if you look at the IDSA guidelines, and we are hoping next week we're gonna invite some of the authors on the IDSA guidelines to speak on PAMA webinar, and they're gonna tell us more about that. But interestingly, they looked at 13 trials, 13 studies, you call them, lack of a better word, and there are only 3 RCTs in them. And the 3 RCTs, they have a very low confidence level in the conclusions. The level of uncertainty is very low, which means they have serious methodology issues. So my point is, the trials are coming, but I would say we need to be careful reading through them.
Yeah, and part of this is, we're getting all this, debate and discussion because there's a lot of pressure from the public actually. And public unfortunately don't have the access and the skills to critique any article or paper. And then and if someone is recommending it, for example, today I have a patient and then he asked me why not you're putting me on azithromycin? I tried to explain to him, but but if he gets worse tomorrow, he will say, yeah, you did not put me, and some people say it's helpful. So this is part of like why it's been like very heated discussion.
I
Another
agree.
one that, yeah, this kind of like more, also there's a lot of conflict about it, probably more for severe patients or like who are in the ICU, is steroid. The Society of Critical Care Medicine just published their guidelines. Actually, they actually recommend very low and a short treatment course of steroid in earlier DS. Uh, I don't use steroid much in people who are on the floor. Probably Majdi can better weigh in, but the IDSA recommendation was against the use of corticosteroid out, again in similar fashion, and it should be in a context of clinical trial.
Yeah, so
And
I agree with you. I think both SCCM and IDSA both said they are generally against the use of steroids in general in COVID-19 patients. But then the SCCM came and said, if you have an ARDS that indicates the disease is severe, then you might try a low dose short course. And the recommendation was weak on the
yeah,
steroid, but you can use it. And the same, the IDSA said, well, okay, you can use it in ARDS, but it has to be in the context of clinical trial, like anything else. They made recommendations about, including hydroxychloroquine. So basically, in ICU patients, when we are dealing with ARDS, I mean, Midori is the hallmark of steroid in ARDS, and it has been a long debate, and literature is quite significant about steroids in ARDS. And most clinicians, including myself, use steroids in ARDS if it's severe, and we make sure if you use it early, not late. And the whole thing is to prevent that fibroproliferative phase of ARDS. And we use it. If you want to go with the Midori protocol, you can use it, or you can use your own modified dose. That's fine. But we don't use it if it's influenza pneumonia ARDS. There have been meta-analyses, a couple of them, indicating harm if you use steroids in influenza viral pneumonia related ARDS. And the first feeling I had, I mean, I should not use it in COVID-19 patients. It's a viral pneumonia. Why should I use it? It's a kind of, if I want to, but again, COVID is not influenza. They are two different pathogens. So
yeah,
I exercise caution. Most clinicians initially said don't use steroids unless there is an indication, another indication for, like, you have a COPD exacerbation, you use steroids. There's septic shock, which is refractory, and you need steroids as a stress dose steroids. You use it. And now we are adding, if you have ARDS on the vent, severe COVID, you can try it low dose short course. And that's what we do. We use it, but we don't know if it's going to help or not, and that's why we need clinical trials.
yeah. And then the problem with the steroid that we don't really, like in other medications, we have some sort of evidence, either like observational studies or like very probably non-controlled clinical trials. But for steroid in COVID in particular, we don't have very like strong evidence. There's like some, if you can go to the next slide.
Sure.
For example, like when it was used in the like in other coronaviruses like SARS and the MERS, actually the outcome was like even it had a bad impact and it was harmful. So, and as you said, like meta-analysis and other influenza, it's like actually it's harm. And there are like some observational studies from China. Actually, it showed some some beneficial effect of corticosteroid, but they were very inconsistent in their doses and the duration of treatment. So we can't really make anything out of this evidence. It just just kind of like yeah, it may not help. So again, I think the steroid should be on a clinical judgment basis and hopefully in a well-designed clinical trial soon. Next. Antiviral, in summary, the IDSA recommendation is there are like two kind of like now very talked about medications, the Lopinavir and Ritonavir, which is a protease inhibitor used in HIV. The IDSA recommended to be used only in the context of clinical trial. And then the other one that is being more talked about, again, part of it is like related to social media news and circulating news, is Remdesivir. Next. So remdesivir basically is a prodrug that eventually will inhibit the viral RNA polymerases. It has been used in previous viruses like Ebola, MERS. Some the effect was equivocal. It showed some effect on some viruses, but not very strong one. It showed some in vitro effect on the COVID and SARS-CoV-2 or COVID-19, and that was like the main reason they they tried to pursue using it in human studies. So far, we have the strongest evidence about it is a study published in the New England Journal of Medicine earlier in April, which was an observational study. If you go next. In 61 confirmed cases, I think 8 of them they dropped out of the study, so they left with 53 patients. And basically, they found that some improvement in their oxygenation. Although this study is published in the New England Journal of Medicine, doesn't make the case that this is strong evidence. This is again observational study, and the company that's making remdesivir is now actually doing a very large clinical trial. Actually, I think now they're enrolling more 4,000, probably 6,000 patients to see the effect of remdesivir. And I think we have to wait before making any judgment about it. The other medication, Lopinavir and Ritonavir, there was also this study, Cow et al. Was published in the New England Journal of Medicine as well. It's a trial that looked for the mortality and improvement in clinical outcome in almost 200 patients. And they found no improvement in mortality compared to the control group. When they used the intention to treat analysis, they showed shorter clinical improvement in treatment. But we have to put in mind that for almost 15% of the patients did not complete the study because of side effects, and it did not really affect the viral RNA clearance at different time points. So the IDSA, as I mentioned earlier, is not to use this medication out of clinical context, clinical trial context. Next. These are just other antiviral medications that have been, being experimenting. Now some of them is being used in a clinical trial, either alone or in combination with other medications. We used to use Atazanavir, which is a viral protease inhibitor used mainly for HIV patients at the beginning of the COVID infection outbreak, but we stopped using it in the hospital. We used it in a combination with Hydroxychloroquine, but there's no strong evidence about it. Similar thing of Ribavirin and Oseltamivir, which is used mainly for influenza. It's interesting to know that the COVID-19 infection actually doesn't use the neuroamidase cycle, which is mainly for the way the mechanism of action for Oseltamivir. So I don't know why they're trying to use it. I think most of their trials are using it with combination other medication. So again, we'll wait for the evidence to come. Next. Tocilizumab is a interleukin-6 inhibitor. The IDSA guideline is to use it only, again, in the context of a clinical trial. There's the strongest evidence comes from an observational study from China on 20 patients. Next. So basically, tocilizumab is a chimeric monoclonal antibody that inhibits interleukin-6 receptor, and then that will lead to reduction in inflammatory cytokines. The main use for it actually to prevent cytokine release syndrome or suppress cytokine release syndrome after CAR T cell therapy. As in all other medications, doesn't it's not a benign one. It has its own side effect. The main one is because of the suppression of the cytokines, actually, it can induces or increase the risk of infection, including bacterial and TB. And the other thing is, like, we have to, point is this is a very expensive medication, at least in our hospital. I think it goes like about $20,000. So using it for everyone doesn't, I don't think, like, will be cost-effective thing to do. Next.
Practical, I agree.
This is the study I was talking about, 21 patients. From all of them actually survived, and it showed some clinical improvement on the imaging and on the blood workup. As an observation from my daily practice, it's working, but who knows, we have to be more specific.
Again, all these observational studies are nothing but what we call them hypothesis generating studies. Like they provide clues that, hey, that might worth doing an RCT to make the right conclusions, but you cannot make any conclusion from an observational study in terms of clinical practice. But they just generate hypotheses, because we don't know what would have happened to these same 21 patients if we did not use Tocilizumab. Just if you leave them alone, what would have happened? We don't know. So the only way to design an RCT. So yep, well, that's one more, convalescent plasma.
The convalescent plasma is again, the IDSA guideline, not to use it out of clinical trial. Next. It's basically, what we're doing is just providing positive immunity for the patient from patients who are recovered from the infection. It has been used in the past, actually. It has been actually has a long history. And if you read if you read through the articles and previous studies done in previous viruses like Ebola and MERS, actually it has some effect on improvement of mortality, which is actually quite interesting. But for COVID-19 patients, we don't have really solid evidence. There's a published study in JAMA with 5 patients who were all mechanically ventilated, who received the plasma, and they're recovered from the ARDS and all survived, but they recovered by day 12. And probably if much you deal with patients with ARDS, some people survive by day 12 or 14 without getting the plasma. So you can make the argument that they survive because of the plasma, or they survive because of the natural history of the disease. So
at those 5 cases, that was in JAMA, and if I remember very well, all 5 cases were younger than 65, and almost all of them, they have no comorbidities. So I mean, that is in itself is telling that there's a selection bias, like those patients are gonna improve. And also they gave the plasma because now what's being offered is after 10 days of symptom start. So they gave the dose 10 days after the course, and by then patients were improving. So again, if you would have left them alone, what would have happened? I don't know.
Exactly.
So nothing but hypothesis generating observation. Okay.
All right. The last thing is this is just showing how does the COVID the convalescent plasma will work. We just take the antibody from a recovered patient, put it on a infected patient, and actually some people, theoretically speaking, that this could be used as a prophylaxis as well if we use a very smaller dose of antibody for example, healthcare worker. It will be interesting to see exactly where this is going to go.
If I just that virus neutralizing antibody, that in the middle of the screen there, that's a very important statement, because now convalescent plasma is going to be offered in my hospital in a clinical trial. There's a MyClinic clinical trial that is going, and we're gonna sign up for it, and our blood bank started collecting plasma from patients who have recovered, but we are not going to do that test, virus neutralizing antibody. We're gonna just give the plasma to the patient without doing that test, because not every patient who recovered from the disease necessarily have those antibodies that neutralize the virus. So, but that's what's available. I asked, why are we're not doing it? They said that kind of test is time consuming, is not available. So we're going to be giving the plasma, assuming it has those antibodies, and look for the effect. Is that the best evidence we're going to have? But no, but at least we're going to have a randomized controlled trial. We're going to have that same plasma given to both arms of patients, and we'll see what the results will be. But that's very important. And also, just to mention that it's not benign plasma. Is aseptic meningitis, just to include the least, but you can have all kind of allergic reactions there.
This is just to show, like, with all this, evidence coming, and how to put it in a context, and develop a protocol. Every hospital, like even within the same area, like now they have a different protocol, different treatment algorithm. This is the one we use as this is like just an example. This is not to to publish or circulate. Is kind of like, how do, at least for the first part, do we kind of like look for the symptoms, look for the comorbidities and the age. If the patient is having any any signs of pneumonia, we start hydroxychloroquine. We monitor them with labs, some of them actually every 12 hours. We put them on monitor. And then if they continue to deteriorate, we use the Tocilizumab. And then in the severe case, we kind of like, at the same time, once they reach this level, we make sure that the ICU team is aware. And then that once they hit the severe area, we just upgrade them to the ICU or probably step down.
And as you said, this is a sample that's not to be used or shared. Each hospital is responsible for making their own protocol, because again, we view the evidence differently, and so protocols, that's why they are different.
And also, by the way, this protocol, actually, they changed so far. They have changed it 3 times.
Yeah, we call them live documents at our hospitals. So, and I caution people in Palestine, for example, to take a protocol from my clinic that was released 3, or like the MGH, they have Harvard, they have their own protocol that was released 4 weeks ago. Well, you might be using it now in Gaza or wherever, but the hospital itself has updated that protocol, so they're not using it anymore. So be careful. Each hospital has these documents as live documents, but these are not to be shared. And each provider actually is responsible for what they choose for their patients till the evidence accumulate.
And the last part is like when we discharge patients. So testing negative is not an indication to discharge patient, and like we discharge them once they are like medically stable to be discharged and go home. I know some, especially in the Middle East, they like require people to stay in the hospital for 14 days. We don't practice that here, and in a practical way, I don't think this is like a feasible thing to do. But the question will come like, okay, do we test them before they go home or not? And the CDC guideline, actually, they have 2 strategies. The first one is test-based strategy, which is like preferably to do in hospitalized patient, immunocompromised, and patient who will be discharged to a long-term facility. And the main reason why we're doing this, like either not test or not test, is to tell the patient, do you have to self-isolate or continue the quarantine or not? So for the test-based strategy, the criteria is that we have to resolution of fever without any antibiotics. At the same time, improvement of mainly respiratory symptoms. And the last part was kind of like we're somehow struggling with is having 2 negative PCR and a 2 consecutive swab within 24 hours apart. The problem with this is that sometimes the swab, the patient will be out of fever, completely okay, no oxygen requirement, but the swab will be positive. Having positive swab doesn't mean probably that they're in the phase of viral clearance and shedding the virus, but probably they're not contagious. And this is like, it's really hard to say which one, or like which patient is, actually, infectious versus not. Probably the antibody testing with either IgM or IgG will give more hint or be more beneficial, but still, like, we're not doing this as of now. The other strategy that we use, mainly for people, who's not going to go to like a long-term facility, or is like just we'll rely on the clinical symptoms, is to have at least 3 days with no fever and improvement in respiratory symptoms, plus they have to be 7 days past since the first symptoms appeared. So for example, if the patient admitted today and like he's been in 3 days he's been off fever, like he doesn't have any fever or any symptoms, but like his symptoms started 4 days ago, he's still required to be in in isolation for another 3 days. So they're using 7 days. I'm not sure exactly what's the rationale or the evidence behind it. Some of the ID physicians and societies actually debating like how long to be quarantined. There's probably another an area of lack of evidence, and we're just using kind of like clinical guidelines and common sense. So as a summary, most of this evidence and studies that we mentioned before is like based on observational studies and non-controlled trials in China, and also based on our experience from previous coronavirus outbreak. Still, most of the clinical societies are against using any of the experimental therapies out of clinical trial context, and hopefully we are going to have more evidence to come in the near future.
Very good. Well, thank you, Rami. Thank you very much for this effort, and we appreciate your participation in this webinar. So if I want to go back, just for our audience to know what we do, like just to give them me as a sample and you, Rami, in your hospital. So for example, for us in my hospital, we vary. All providers, they do different things. But for me, I do hydroxychloroquine, and I combine it with azithro if the QTC criteria is favorable, and we have very strict follow-up on the QTC. So we use hydroxychloroquine plus minus azithro, and especially if I'm treating pneumonia, I use rocephin and azithro for the community-acquired pneumonia, in addition to hydroxychloroquine. So this way I'm combining hydroxy and azithro, but I don't combine in all patients. And whenever I use either or both, we follow a very like a daily QTC. You mentioned Q4 hours. We do it every day, and we make sure the QTC and the tele match and like corresponds with the EKG QTC. So for steroids, as we said, we use it in severe cases, and for like we do like 60 milligram daily for 5 days and we stop it. And only in severe cases, those are on the vent, they have ARDS, severe cases, and confirmed COVID and all that. Anticoagulation, I don't use it in all patients. I use it, I have low threshold for it, but definitely the DVT prophylaxis, we use higher than usual doses. We use 0.5 milligram enoxaparin if normal kidney function. Otherwise, we use 7,500 units of heparin sub-Q every 8 hours. Antivirals, we don't use any in our hospitals. Remdesivir we tried to get it as a compassionate use, but they are only offering it for pregnant women, not for anyone. And they have a clinical trial. They were not interested in our site because we didn't have the number of cases they're looking for. So we don't use any antiviral now. Tocilizumab, I used it twice in our patients, but we are not using it in general for COVID-19 patients. And as you said, it's not, you cannot offer it for all patients on the long run. Expensive, it's not that available, and we're only going to be using it in a clinical trial context. So plasma, we are planning to get an IRB approval for a clinical trial. So we use then hydroxychloroquine, steroids. I don't anticoagulate all patients. I don't use antiviral, Toci, and convalescent plasma in a clinical trials. How about you, Rami? What do you have on the list?
So it's quite different. It's not like a totally different, but it's kind of like hydroxychloroquine. We use it for anyone who is like as per the protocol, if they have above 60 or 65 with comorbidities and they have a pneumonia. Then steroid, we use it mainly for people who are on ARDS. The protocol, I think, 40 milligram Q8 hours for 3 days, not 5. Anticoagulation, as I mentioned, like for the intermediate with people like rising D-dimer, we use it 0.5 milligram, and we give prophylaxis for everyone. Antiviral, at the beginning we used to have Remdesivir, but we stopped it. And then now they're enrolling, or like they had a few patients on Remdesivir, and now they on hold because they're updating the protocol. I'm not sure exactly what they're like, what they're doing with the protocol, but it's for now it's on hold. I guess they're gonna continue enrolling patients. Tocilizumab, we're using, well, like at the beginning we used kind of like use it as a candy. Like anyone who's desatting, we just kind of like give Tocilizumab, and like if they have a CRP more than 70. Now we're kind of like trying to be more restrictive and like look for the age, if they have dementia, like what their liver function test and what their cardiac function test as well. So we're trying to preserve it for people like who are like probably more healthy and with less comorbid disease. I'm not sure about plasma. I haven't heard about any case yet in our hospital.
Sure. Well, Rami, I think the next section is going to be mine. So we're going to take a little break here. And this way we have our lecture in 2 pieces. So I'm going to stop recording. But before that, again, thank you, Rami, very much. I hope this info will be useful, meaningful to those who are listening. And we gonna record that and publish it to whoever is interested in it. Thank you, Rami.
Thank you, Majdi.
Thank you.